Please take your seats. The program will begin momentarily.
Gotta go. Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Welcome to today's session on consolidation in the healthcare sector. We have a great panel and program prepared for you. I'm going to briefly introduce the subject and then we'll get into the conversation. So if it seems like everyone in healthcare is buying up someone else or being bought by someone else, that's not your imagination. I'm the editor of a health policy journal, and we've published a lot on healthcare consolidation, so I thought I'd give you a few data points. If you want more, you can look in the journal. If you go back to 1950, fewer than 5% of hospitals were part of what we would now call health systems. The share now is about 70%, so the transformation in the hospital sector has been profound. Many of these systems are local or regional, but about a third of hospitals are now part of national systems, which is also a relatively new trend. Physicians, of course, are also consolidating. They're increasingly in larger groups, and they're increasingly in practices not owned by other physicians, but by other entities. Many of them are hospitals. And depending on where you live, it's very likely you actually have very little choice of provider. When we think about relying on markets and competition, that's hard when there isn't much. And in 90% of metropolitan areas, the hospitals are essentially fully consolidated, very few players. 2/3 of metro areas, you'd find the same for specialty physicians, and we're now seeing it in about a third of metropolitan areas for primary care, a relatively recent trend. So the session title asks if consolidation is a cure-all. I actually haven't met anyone who thinks consolidation is a cure-all. But our goal for the session is to really give you an understanding of the pros and cons, because I think there really are both. Consolidation can prop up failing enterprises and bring about efficiencies. It can allow for clinical integration, which can benefit patients. But as the research we've published shows, it can also increase prices. In fact, it pretty clearly does so. And so the question that we'll leave you with is, as you have a better understanding of the benefits and the downsides, how do we think about this and navigate the ups and downs and maybe make sure we maximize the positives without having too many of the negatives? So we have a great panel to discuss this topic. I'll start at the far end. I have Joe Bedencourt, president of the Commonwealth Fund, an internist, former senior vice president for equity and community health at the Mass General Hospital, will provide, I hope, a clinical perspective on this. Erin Fousey-Brown, director of the Center of Law, Health, and Society at Georgia State University. In a matter of weeks, will be making her way to Brown University School of Public Health. And immediately to my left is Ken Davis, Executive Vice Chair of the Board of Trustees of Mount Sinai Health System, a neurobiologist. He was previously the CEO of Mount Sinai, and we've shared the stage a couple of times here, so it's a pleasure to have some time with him yet again. So we're going to start, as I suggested, with some of the benefits. I'd really like to hear, and Ken, you sort of told us a little story in advance of this session. You had no difficulty seeing what the potential benefits were financially for struggling institutions. Maybe you could start with that story.
Well, we were contacted about 10 years ago by New York State. And they said, the continuum healthcare system, it's going to go bankrupt. We want Mount Sinai to take it over. Really? And we worked it out, and it's been a challenge. I mean, they have a problem like a lot of the hospital systems in New York. And let me give you a sense of why New York is different from what you're going to hear from other people. We are a state in which all the hospitals have to be not-for-profit. And also in New York City, particularly around where Mount Sinai is, think about this. We have NYU, New York Presbyterian, and New York Hospital. We have Memorial Sloan Kettering. We have HSS. and Mount Sinai. We have then 5 hospitals within 2 miles of each other that are 3 of them in the top 20 in the national rankings, and 2 of them are the brands in cancer and orthopedic surgery. Competition, we got plenty of competition. It's not like this is an unusual market. And none of these groups are looking to consolidate and get together. So we took over the Continuum hospitals, and then we were approached by a hospital in Long Island who said, we don't have the facilities, the infrastructure, and the tertiary care to compete on Long Island. We need you to join. So we joined with South Nassau. So that's our system, and it's hardly a system that gives us any leverage with the insurance companies. We have a tremendous amount of Medicaid, a tremendous amount of Medicare. Nearly 50% of what we do is Medicare and Medicaid. It gives us no leverage with Aetna, United, all the big guys. So consolidation in our case has been to save systems, to improve quality, to facilitate infrastructure and care, and it has not been to increase our bottom line, which, by the way, is pretty pathetic.
So as you started out, New York isn't the typical market, and I wonder if either Joe or Aaron would like to sort of round out the picture with some other ways that the market is structured.
Yeah, I think that, that's sort of what we would like to see in most markets, is a healthy competition, multiple competitors, competing on brand, competing on patient care, and that is what keeps not only the prices in check, but also quality, and gives people choices, and I think that's what people want. The majority of hospitals, and not just major metro areas, but I would say certainly rural areas as well, cannot support that much competition. And in fact, what we're seeing is that the amount of competition has eroded to the point where the vast majority of healthcare markets, particularly hospital markets, are highly concentrated, meaning there's really no competition meaningfully left. And so what that means is that when we see consolidation, we know that what the evidence says is that consolidation, not just this hospital buying its neighbor hospital, but the hospital systems buying up all the physician practices, the cross-market, all the different hospitals across state lines merging to form a giant like Ascension or another type of large healthcare conglomerate, that's the norm. And increasing what you hear from providers is that or hospitals, you can't stay independent anymore. It's not possible to be a small independent community hospital and keep up with the demands, the data, the infrastructure. It's just too expensive. And so I think in some ways, consolidation is its own driving force to beget more consolidation, because it's to the point where you have to be big to survive. And that, what we've also learned from the evidence is that once a system is consolidated, nonprofit or for-profit, although I think there's certainly some evidence that certain types of for-profit hospital ownership can be more pernicious, like private equity ownership, we do know that there is a need, once you have the market power, almost in every health system that acquires that market power uses that market power, both to raise prices, but also to sometimes shut down those service lines in the name of efficiency, in the name of centers of excellence, but that means that the community might lose its labor and delivery, or the community might lose its hospital or lose its NICU, something that the community really struggles with, even though, yes, maybe from an efficiency standpoint, it makes sense to funnel that into the mothership of the hospital system. So I guess that's what I'll just start with.
And I want to tie in, 2 important words that were said here: cure-all and hospitals surviving. Mm-hmm. And I think what we're not talking about is the amount of money that we spend as a nation and what we get in return for it. So we're almost asking the wrong questions about the value that consolidation brings. I thought I might share a couple of reflections as someone who served on the board of a large health system that went through a large national merger, as well as somebody who was part of a system that was a confederation until it became a system. And I think there's no doubt that there's consolidation fever. And a lot of times the premise upon which is built is systemness, effectiveness, removing administrative burden, being able to improve quality, and this kind of tension between financial and clinical integration, no doubt. And I think in our early conversation, it's apparent that no one consolidation is equal. You have consolidations that you discuss where a large system is asked to step in and save an ailing system. Nobody's running to save Steward Healthcare right now in Massachusetts. In case anybody's interested in that auction, I think it's coming up soon. But, here's an example where people aren't stepping up. Those are communities who are vulnerable. If we're really thinking about improving the health of Massachusetts, it's created quite a crisis there. We have consolidations, I think, in markets where, yes, competition is the goal, and getting more market share within a market is the driver. But constantly the guise is improving quality and what we discussed here, decreasing costs. And sadly, the evidence shows that, yes, we're not getting a benefit on costs. The quality is, it's kind of a wash. And I guess the other piece I'd like to bring in is that from a workforce standpoint, we are seeing the signs and symptoms of a healthcare workforce that's getting frustrated, kind of being a pawn, if you will, in these large transactions, losing agency. And in return, we're seeing the vestiges of organization, of unionization of healthcare providers as a way to kind of combat this, among a lot of other things that are creating demoralization. So it's an interesting kind of cascade of events, but I think we really should be asking, does consolidation improve the health of the American public? And I don't think we see that evidence playing out.
So I'm really glad you brought up the workforce. I'm glad you brought up a lot of things, but that one to end with, because if everyone is viewing this as a financial transaction and they're just a bystander or a victim, that can't lead to good outcomes. And when we look at the long-term trends, we do see clinicians, physicians in particular, consolidating. So what I'd like to do is push a little bit on sort of the differences between horizontal and vertical and cross-market. Again, this may sound a little bit like jargon, but it feels very different. So you can have all of the orthopedists in a market come together and create a consolidated, a unified organization. You can have the hospital come and buy up those practices and also buy the primary care practices. And Ken, you've mentioned the role of insurance, and of course, with the exception of something like Kaiser, where they really own everything, some of this is seen as defensive against the forces of the insurer. So can we just go a little deeper in sort of, you alluded quickly to the Steward situation. I'm not sure everyone here knows a lot about it. Let's just talk a little bit more about the different forms that this can take.
Sure. Well, I mean, I lived through the Steward situation in Massachusetts, Catholic health system, Caritas Christi really failing, and private equity coming in, something we're not necessarily talking about on the panel.
But I think we should.
But yeah, I mean, I think it's all part of a series of actors right now that we're seeing in this story of how healthcare is evolving, no doubt. I think early on we anticipated, particularly with the private equity play, that down the road there might be problems. These were hospitals that to some degree were in challenged markets as it relates to payer mix. And the concern was, most of all, the intentionality of that purchase of those hospitals, saving those hospitals, and where that would lead. And I think it's played out in its worst cases now. A lot of the value, particularly through a real estate transaction, was stripped away. And this is now a national story. This is not just a Massachusetts story. Steward began in Massachusetts, but expanded nationally, based in Dallas, largest for-profit system now. And now we have a bankrupt system where a lot of the value has been extracted. Those hospitals sit on land owned by a REIT in Alabama, who now is going to be charging anybody who buys those hospitals rent, and it's not going to be cheap. And on top of that, those hospitals are in a situation where the investments, the fundamental investments you needed, I think were stripped away. And the notion that you're trying to increase revenue and decrease costs plays out in decreased staffing, less attention to quality, and all the metrics that would yield. And that's what we saw play out. And the warning signs began. The state interceded, but the state said, we're not going to bail this out. And so right now they're in bankruptcy. There's going to be an auction, and so it really is a worst case. And so what's the upshot of this? People in these communities, a workforce at those hospitals now, who are in deep trouble, in a state who, despite, talk about markets, has incredible capacity, is incredibly capacity challenged, and is now figuring out how are we going to both integrate those patients into the system, 16,000 individuals in the workforce in Massachusetts. So this has become a big problem, and I think it may be the canary in the coal mine that raises, I would argue, already some bipartisan support around, these types of transactions.
I think the workforce issue is a real issue. I've seen, and in New York State, the large practices of physicians are for-profit. And Optum has come in and taken and bought some very substantial practices. And a lot of those doctors come to me or to our system and they say, we want to leave. So why do you want to leave? Because I can't deal with what's going on here. They've changed everything. They're looking at how many patients I see, how quickly I see them. They're not interested in the kind of medicine I used to practice, and they're very uncomfortable with that. And I understand that. I mean, we entered medicine not to touch a time clock, not to make sure that we saw 20 patients a day for 20 minutes each. We wanted to help people and care about people. And suddenly, there's a different motive. And I think where we're headed is we've got to begin to think about regulating this industry. So that we continue to have the core values that we really think are so critical.
Yeah, and I think one of the themes that we're hearing is that, who's the one buyer that stepped up to the steward to buy the physician group? It's Optum, right? And Optum is
United.
It's part of the largest we're not even talking about the healthcare conglomerates run by the insurance companies. The United, Optum Rx, PBM pharmacy chain, all the way down, group purchasing agreement. It owns the whole thing. And it's in this this giant behemoth dynamic that I think that you're right, the patient and the community and the clinical workforce get absolutely trampled. And I think that one of the things you asked about, what are the different types of consolidation? I think historically the antitrust agencies thought horizontal consolidation is obviously bad because, you get a monopoly, two neighboring hospitals decide not to compete with each other anymore, prices go up, they have market power. But vertical consolidation, physicians being integrated into an integrated health system, that could create some efficiencies. If the payer, managed care, if the United also is coordinating the back end, if it buys Change Healthcare, what could possibly go wrong if United buys Change Healthcare and the DOJ was like, no, that's really scary, but the courts basically were like, but it's vertical, so we're not really sure what the problem is. And then cross-market is like, well, they're not even competing in the same market, but the evidence is starting to show that every single type of consolidation, horizontal, vertical, and cross-market, increase prices and tend not to have any meaningful improvements in quality. And so I think what we're faced with now is what do we do about it? And I think that.
So I want to underscore for the non-lawyers in the room,
yes,
how important it is to understand the long history of the assumption that horizontal was a risk because it would put pressure on prices, but that vertical, there was always a story of better clinical integration, better administrative efficiencies, and there didn't seem to be a lot of risk. And what you're pointing out is that there's this new understanding of risk, but the regulatory regime is still stuck in this old world of seeing these as qualitatively different. So I'm really interested in, we've started to broach the topic of regulation. I assure you we will get to it. But before we go full into that, one of the things that regulation is not very good at is differentiating between different transactions that have different motivations. Like, the regulator can't say, why did you do this? Oh, you can't. Oh, you can. So how do we, from the outside, we can sit here and say, when you... the story you told at the beginning, Ken, is one of a bailout, in essence. The motivation was to preserve the asset. We've now heard stories, of where the motivation is to drive up prices or to extract resources. That's the motivation. But if you're sitting there from the outside, how do we differentiate between those early enough that we're not asking the regulators to read the minds of the people doing the transaction, which is something they can't do?
I think we really have to look at the P&L and the patient mix of each of these systems, and everyone's unique. In our system, with so much Medicare and Medicaid, we lose 35 cents on the dollar in every Medicaid patient, 15 cents on the dollar of every Medicare patient. I mean, we struggle. So if and there isn't, this doesn't exist, but if there was some if there was some community hospital that was printing dollars that said, we really would like to be a part of the Mount Sinai infrastructure, I'd say, join us tomorrow. But that's not happening. So every case is somewhat unique. And when it's all about avaricious outcome, that's got to be regulated.
But I have to say the data, maybe you were going to go here, I promise I'll let you. The data show that this is a really big problem for rural, where the assumption is that we can only survive if we merge. And yet the evidence show that after the merger, a closure is just as likely. And so part of it is getting out of the mindset that that's the only fix. Sorry, Aaron.
I think that's a great point to make. And one of the things is, I think rather than try to read the minds, because the private equity group, that bought Steward, promised up and down that it was going to do exactly the same thing. It was going to bail out and invest in the communities. And in fact, it did just the opposite. And so maybe it's a matter of regulating the behavior and saying, like, okay, so you're not going to be able to raise prices. And this requires some level of regulatory overlay, of oversight of the transaction. You can't raise prices. You can't close essential services. You can't just shut the doors of the hospital that is the least profitable, read the one that has the worst payer mix that is also most needed in the community. And that these have to be conditions that are held in perpetuity, not just for 5 years, not just for a brief period of time. But if you want to get big in order to take advantage of these economies of scale, then you have to promise to live up to those commitments, to make investments in behavioral health and primary care, and to keep the doors open.
And to be held accountable. I mean, I think, I want to be clear. If our kind of the statistics around our nation's health were booming, then I think we'd have no problem here, right? We'd say, okay, well, we've chosen a market-based approach to healthcare in the United States, like it or not, and we understand that capital and investment is important. But when does that go out of balance such that financial value becomes the lead as opposed to value, which is investing dollars and getting health in return? So not health creation as opposed to wealth creation. And I think when we ask these questions, we need to say, do we have the right regulatory structures in place, right? So Navant is a great case study today that we're looking at. Use the fail firm argument to want to kind of acquire two systems out in the rural area, in North Carolina, and made that argument to the FTC, and the FTC, didn't buy it. And so Navant has now pulled away. FTC wins a lot, actually. They just don't get into the fight a lot. And what's fascinating is I think they've won their last 10 from something I recently read. A whole series of modern healthcare listed out the FTC wins. But they've had in the last 10 years, they've challenged and won about 13, of which 200 were by kind of external auditors likely challengeable and potentially, from a competition standpoint, probably shouldn't have gone through. And so the question is, are they the right vehicle, sole vehicle? Are there financial thresholds, accountability thresholds around around health performance that are necessary? Is the threshold by which they look at these transactions at the right points, about $120 million now? What's the role of states? Is there a need for a different agency that looks at not just financial value, not just is this about a problem of competition, but actually can this add value in health? So I think these are the questions we need to be asking. I don't think the current structures suit us well, not to mention private equity oftentimes acts in the shadows, even more so in some of these transactions. So I don't think we're here begrudging private equity or consolidation. We need evidence that it's improving the health of the American people. And if we get that evidence, I think we can support it. There's no one consolidation, I think, that hits a home run in that space.
So I want to follow up, Aaron, on your comment about sort of the motivation here, not from looking into the souls, but looking at the opportunities that consolidation creates. And if there were fewer of those opportunities that were bad for the health of the community, then there would be less consolidation of the bad kind. And so we talk about regulation, but I want to tease out a little bit more sort of the financial side of what actually happens here. And I guess I'm going to put out two scenarios, and I'd like you who know a lot more than I do to make sure I've got them right and add to them. So one is the jacking up of the prices. You have more market share, you can now charge more. And if if there were fewer opportunities to charge more, then it would be less appealing to consolidate. The other is sort of the asset stripping that we've described, that you come in and you take, whether it's through the REIT that charges a high rate or high administrative fees or something, but you basically have ways of shutting down non-profitable lines and take the assets and run. Are those two good starting places? Are there more that we should be looking at? Because it seems to me if we want to, taking, Joe, your comment about the limited number of cases that any one regulator can bring, if we want less of the bad stuff, then probably we want fewer opportunities to do the bad stuff. And that means figuring out what the bad stuff is. Yeah. Erin, can you help me here?
Yeah, I mean, I think that those are some of the harms, right, is the price increases. And it's not just the market power related. We can charge higher commercial prices because now we have the size to do it. We have the must-have health system. But also there are these because of the complexity of the way healthcare is reimbursed, there's the site of service differential. So if you're a health system and you buy all the physician practices, you turn them into provider-based hospital outpatient departments, all of a sudden you can tack on a facility fee and charge more. And these are all part of the calculation. 340B, right? The ability to leverage the 340B, payment model is like driving a lot of consolidation.
And just for those who don't know,
yes.
Right? So that's a significant discount on drug procurement prices if you're a qualified entity, and you're not required to pass those lower prices on. You can basically.
Sorry,
I just want to make sure.
Yes, sorry. Jargon. But I think that's, and then the other being the cost containment, the things that we think of as asset stripping or the reduction of service lines and the cutting of staffing. And those things I think are certainly very much not traditionally in the analysis of an antitrust authority, and I think that you're absolutely right. State regulators like the Health Policy Commission in Massachusetts and the healthcare market oversight body in Oregon, they have more of a mandate to look at things like staffing and quality and access and equity. Equity is a big piece because these are not resources that are stripped equally across the system. It's always the most vulnerable communities. So I think that that's absolutely right, is to think of sort of like name all of the factors, and it can't just be price. And then some entity, and we have to figure out who it is, has to have an eye on the entire picture.
It's very attractive. Like the selling points for consolidation are very attractive. They make sense, right? So in systems I've been in, you're going to have greater efficiencies, greater connectivity, greater communication, one kind of layer of quality. So there's a lot about it that to the naked ear is like, oh, that of course, that sounds good. More access. So I don't think that there's not circumstances where that component doesn't actually add value, but at what cost? And at what cost financially, and at what cost to the communities as well, when those prices go up, when the payer mix shifts. So I think those are the deeper questions that are critical to tackle here on a go-forward basis. And
Ken, you started by pointing out a nonprofit market. But again, for those of us who study healthcare, a lot of nonprofit systems their behavior is pretty hard to differentiate from for-profit. So I wonder how important a factor that really ends up being.
It's probably not very important at the end of the day, although, no private equity is looking to take us over.
Right, that's.
We have
that's a pretty big difference.
Right, we have that advantage. But, one of the things we haven't talked about, I think, is the savings in the corporate expenses. When we took over these other hospitals and they were all failing, the first thing we said was, we're never going to be able to sit down with United and Aetna and Blue Cross and say to them, oh, look, now that we're a couple more hospitals, we expect you to increase our rates by 20, 30%. Far from it. I mean, the negotiations that we've had with the insurance companies are not believable. They've got all the power, at least in our market, because it's a divided market. Now, maybe in some of these consolidations, and I don't know how many markets are like this that you're talking about, they're so dominant that they can sit down with United and say, this is what you're going to have to pay us. Not our experience. Our experience is quite the opposite. Our experience is that because there is essentially a monopoly here in insurance companies, you have so few of them to deal with, they're killing us. On top of that, in the last 2 years, their business model has been to double the number of denials. So when we sit down with them and we say, how about an independent review board for those denials? They look at us and say, huh? And then they say, well, you know, it'll be our people who'll review it. It'll be independent, but it'll be our people. Really? So anyhow, I think what we're missing so far from this conversation is the power that these insurance companies have over us. Because remember, the Medicaid and the Medicare rates, they're fixed. The variability here is what you can do with the insurance companies. And in our case, because the competition is so severe, it's very, very limited.
And if I may add one more scary thing to consider, and one additional worry that we have about consolidation, in addition to price and access and quality and workforce, is the threat of cyber attack. And this is not just a theoretical construct. We saw this year, United and Change got, shut down for essentially, I think, 12 weeks or 12 plus weeks, where the ripple effects of the claims processing arm of United Healthcare meant that providers, hospitals and physicians and pharmacies could not be paid, and they were thrust into a financial crisis that was because Change was basically locked up. It was not processing payments, it was not processing patient orders, and patients were the ones suffering. But it's not just the insurance companies that can be targeted. Ascension, one of the largest hospital systems, is still suffering from a May 8th cyber attack that has essentially crippled their systems. And so one of the things, everyone's like, well, isn't there HIPAA? Well, HIPAA doesn't provide any protection against cyber attacks that we think of like our key infrastructure, pipelines, our grid, our water supply. We have to think of our healthcare system in the same way, especially when it gets so big, that if you can take down one pipe change, or you can take down one health node of a health system that sprawls across 20 states like Ascension, then you can take down entire regions' health systems. And that's a very scary thought, and I believe there's no one sort of looking out for what do these systems need to do to protect from the cyber threat, the fragility of not just ordinary concerns of consolidation, but this emerging threat.
Yeah, and I'd say, as we've seen in the financial industry and healthcare, oftentimes the rescue flare goes out to the taxpayer, right? It goes out to state government, federal government to, hey, can you help us here? Because of these practices that have increased risk, increased, I think, the vulnerability of communities. So that's the kind of the double whammy that you get, which I think is challenging.
Another non-financial consequence of consolidation that should be brought up in a forum like this is when the consolidation of hospital services is under a religious order that does not provide access to certain reproductive services, that is also an access barrier associated with consolidation that has nothing to do with prices.
Right.
So we've teed up the topic of regulation. In the abstract, regulation always sounds like the answer, right? But it actually turns out that we're not so great at regulating, just like markets sound theoretically like a great answer, and then they don't always give the results that you'd like. So let's just, before we turn to the audience, which we will do soon, so please get ready with your questions. Let's spend a little time on sort of what is the current oversight. And Aaron, I've had the pleasure of being in a room with you a number of times. You are really one of the creative leaders in the country in thinking about appropriate and redefined regulation. So if we were to say the market is not going to fix this, we need a regulatory regime, we have one, it doesn't seem to be up to the task. Where do we go from there?
Well, I think in some ways here the states have been the innovators on some of these regulatory approaches. So one thing that the Massachusetts has done and that other states have followed suit is this healthcare transaction oversight. It sort of pairs the traditional antitrust review. You get notice of more transactions, of the little transactions, the big transactions, the private equity transactions, and there's a body that's equipped to look at not just the competitive effects or the price effects, but of the effects on access, on quality, quality on the workforce. And that has a mandate really to do that, and the ability and data to make an assessment and to make a recommendation, usually to the Attorney General or someone else who's empowered to block or put conditions on the transaction if it's allowed to go forward. And those conditions can be then a form of accountability to make sure that, doors aren't closed, that key service lines aren't shut, that prices don't increase overnight. And so I think that's one very promising model, and even Massachusetts realized that despite their ample authority, they couldn't prevent the Steward crisis. So there's a bill pending right now in Massachusetts that would say real estate investment trusts are a form of transaction. If you're going to strip off the assets of a healthcare entity like a nursing home or a hospital, then that has to go before the regulators, and that there are certain types of management service organization contracts like United's Optum does, or private equity companies use to control medical practices, that would be also under scrutiny. So there's sort of this idea that the state has, in some ways, a larger ability to coordinate their oversight. All of this takes resources. None of this is cheap or easy. And then there are other things, of course, then, even if you can't stop consolidation because your market is already consolidated, then there needs to be some concern about, are there anti-competitive payer-provider contract terms that are being used to basically eliminate competition and increase prices and reduce access. And then there are other types of, even rate regulation, and it doesn't have to be the 1990s version of rate regulation. It could be something where you could tie caps, put caps on the total rates that the most powerful dominant hospitals can charge, maybe even put a floor to support those struggling hospitals, and create some sort of a regulatory corridor, maybe tied to Medicare, maybe tied to some other reference or benchmark, a multiple of it, so that there's some, running room within which the system cannot fluctuate too wildly, maybe just to control some of the worst effects of consolidation. But I think that those are all potential options.
Yeah, I think in Massachusetts, we had a lot of the right ingredients. I think the enforcement part was the part that was lacking. I mean, Health Policy Commission was asking for financial data from Steward forever. And they just tied it up in the court, tied it up in the court, tied it up in the court until it was too late. And that often becomes the kind of tactic of kicking the can down the curb, is just, okay, no, we don't fit. No, why do you have this information? I mean, they tied it up for years. So I think the ingredients are right. I think revisiting what the right enforcement approaches are. But I think, back to Ken's point, I think we do need to understand that a lot of people are playing defense, and this notion of defense shouldn't be downplayed. I mean, there's legitimate concerns around how can you began by saying, and our margins are this. Hospital margins are 0.3%, 1% at best. So playing defense is kind of for survival, some degrees of reality, and so you band together. There's a set of behaviors that I think emerge from that playing defense. That makes sense.
Another very small piece of this is, in New York State, Department of Health oversees our hospitals. But the reality is that they listen to the public all the time. And what you get is a group of small activists who can get media attention because it's good headlines for the local papers, and they're screaming and shouting, and suddenly the DOH is paralyzed, and nothing gets done.
Yes. So regulation is subject to politics, I think, is what we have to remind ourselves here, both in terms of the resources available to actually enforce it, and what happens when you say, well, we should use that force in a firm way, and they're vehicles for pushback. Well, we do have some time for some questions. I thought there might be a few. You've got to use a microphone. You have to tell us who you are, and you have to keep your questions short. And it looks like there's a mic right there, so let's get these two right here, and we'll keep.
Hi, I'm Dr. Elliot Levy from Miami, Florida. I'm a retired physician, but still actively involved in healthcare. Listening to all the descriptions about the problems you have with dealing with insurance companies and with private equity, do you think it's time to revisit the concept of single payer or something along those lines? Or do you think the insurance companies are so powerful that they'll never allow that to happen?
So as moderator, I'm going to say, if we want to have a discussion about single payer, we need a whole panel. Right. But I think we should at least ask the question, what directionally would that do with respect to some of these issues?
From a price standpoint, it might help, but it depends what form it takes, right? And if it was Medicare Advantage for all, then we still have the same problem that we have prior auth and all the things that you're worried about.
Right. I mean, if they're going to, single payer is going to be Medicare for all, we'll be out of business. I mean, we cross-subsidize with our commercial rates.
And right behind was, yes.
Although I just say this question is coming up more and more.
Yeah.
Which leads me to believe that, a lot of the boogeymen about single-payer access issues, affordability issues, I think people are experiencing a lot of that here in this country today.
Yeah.
And then when at the Commonwealth Fund, we look year after year at international comparisons, and, again, year after year, we're an outlier, and we have exceptionalism in all the wrong ways. And what is unique about all the countries that beat us is that they have a single payer. It's not judgment, it's just evidence here. So this question is coming up more and more as this pendulum, I think, is swinging to dissatisfaction among patients, providers, and the like. So it's interesting that we've heard it in a variety of different venues recently.
Sure. Anna Jameson from General Atlantic. I'm a director there. I'm also a social work graduate student at Columbia. So one question that I have is that consolidation was a strategic decision made by hospital leadership across the market. So 3-5 years from now, what are strategic decisions that will not produce these same results? And how can hospital leadership work together in order to drive different results than what were produced today?
Wow, that's a good one.
Oh, absolutely.
Everyone wants your answer.
I wasn't precisely sure. Look, I hope what you're saying is hospital leadership has to focus on quality. At the end of the day, we have to make sure that our outcomes are as good as they can possibly be, like we have in Europe, and that our healthcare workforce is adequately reimbursed and feels that their job is worthwhile. And then we still have to figure out how to make sure that these hospitals that have a large amount of public patients, where you have all the healthcare inequity, are still functional. These are things that are not going to be done by my sitting down with the other CEOs in New York State and saying, what are we going to do? We need the public to really get angry. When people talk about healthcare inequity, Black and brown people aren't getting treated the same way. Their outcomes aren't as good. What upsets me the most about that is in New York State, the progressives who represent those districts, who should know better, sit around when the budget comes through and they institutionalized inequality by underfunding Medicaid. So if you're going to be serious about healthcare equality, pay for Medicaid just at cost so that we can take care of everybody.
I can't see very well because of the light, so the folks with the microphones in some sense are my eyes.
Hey, Seth Gold from the House Energy and Commerce Committee. We talk a lot about some of the misaligned financial incentives like 340B and maybe site neutrality that may potentially drive consolidation. And there certainly are a lot of, to use baseball analogies, like home run ideas that could potentially solve those, but those can be contentious. So to continue that analogy, are there singles and doubles approaches that could be somewhat effective in addressing consolidation, but also conversely for policymakers, are there ideas that are too small that it's not even worth addressing in the first place?
I mean, I think that if there was a home run idea, I don't think it's out there. I haven't heard it. Healthcare is too complicated and it's too easily gameable. So I do think that the singles and doubles approach is the way to go. And I would say the ones that you talked about, site neutrality, 340B, those are great places to start. And I think that there's a lot of need to look at the sort of, not just the payment policy, but what are the enforcement, particularly antitrust enforcement authority to kind of get at not just mergers and acquisitions, because we know a lot of places have already consolidated, but also anti-competitive conduct. So increasing the budget and the resources and the statutory authority of the DOJ and the FTC to start to encompass more of the things that we're worrying about so that they can have notch more wins. I think that those would also be, I mean, I could go on and on, but I think that's the right approach. Insofar as if we're not in a position to make large systemic changes, to move towards something like single payer, then we need to do what we can to eliminate the sort of inefficiencies, the gameable arbitrage opportunities that are in the system.
Well, we can also consider taxing the insurance companies and their profits. You know, I mean, they're making it on our back. Think about this. Medicare Advantage comes from Medicare that we pay in our taxes. And these Medicare Advantage companies like United are making a fortune over it. Is that the right thing to do? Was that the goal of Medicare? So there'd be these margins for the companies to take away from the care? I think we should tax it. We should get the money back and give it back to the hospitals.
So I know I'm supposed to be the moderator, but I have to, your baseball analogy, singles and doubles only are helpful if you turn them into runs. And one of the challenges we have is that Congress will hit the single and then never follow up to turn it into a run. So I'm thinking of the prohibition on surprise billing, where that was a huge effort to get it passed. I also think about penalties on excessive readmissions. We learn, and this is my bias as the editor of a journal, we learn over years about what is and isn't working about those, and then we need to fix them so that they can have the potential effect. So it's not just hitting singles, it's being ready to build on the runner on base to get them home.
Yeah, I just say, you know, it's important for us to think about the home runs, because healthcare is a shapeshifter, right? You have a river with several streams, and you put two regulations, you dam up two streams. It's, you know, this river is 17.9% of our GDP, finds 5 other streams. That then it takes us another 3 years to catch up with regulation. So I think the singles and doubles are good, but I think we're gonna, you know, we hit 2 more singles and doubles. The other team's always gonna take the lead, unless we think of something and do something more dramatic.
Yeah, the speed is, I'm glad you brought that up. Are we probably, yes, here we go.
Thank you. Refreshing conversation. Beto Lopez, Austin, Texas, Cura Health Fund. We have over 100 years managing monopolies and monopsonies at the state level when we deem the resources, the goods and services as essential. Gas, water, electricity. They're called public utilities. So much of what you're saying points to public utility frameworks and models. When do we begin to see the facilities in healthcare as a public asset that we can all benefit from by adding layers of services to those things? It seems like you guys are on the cusp of saying those things and yet don't want to say them, or maybe have reasons for not saying them, so I'd love to learn why.
I actually strongly agree with you. I think that we are at a point where we are seeing our systems becoming too big to fail, and we need to treat them like public utilities that are essential to the functioning of our society, and then think about ways to manage them, to regulate that resource, to make sure that they can stay functional and profitable in order to stay open, and innovate, but also to not necessarily be subject to the sort of political wins and the capture and all of these gaming opportunities. So I think that is absolutely probably the next step. Whether that is in the form of single payer or a public utility model, I think that is absolutely the right way to go.
That was consensus, okay. Yes.
Hi, my name is Karen Landman. I'm a health reporter at Vox News. Somebody mentioned the FTC victories over the last 10 years, and I'm thinking about a loss recently in Texas against private equity. It was sort of supposed to be a big landmark case, and it did not go the FTC's way. And I'm curious if one of you could contextualize that and talk about what that portends for the FTC's future against private equity.
Yeah, so this is the FTC's case against U.S. Anesthesia Partners, a large private equity-backed anesthesia group that has essentially monopolized the anesthesia market in the state of Texas. And so that lawsuit, you're right, is ongoing. It's a landmark case because it's the first attempt by the FTC to go after both a private equity investor, but also to go after this serial roll-up, buying a bunch of small practices and rolling them all up into one big, giant medical group. So this strategy is one that's used not just by private equity, but it is used a lot by private equity, but it's also used by Optum. And so what survived that recent loss was that the case against U.S. Anesthesia Partners for the serial roll-up monopoly strategy is alive and well. So the serial strategy is seen as potentially anti-competitive, so that is going to still continue before the court. What was sort of the setback was that the private equity company, Welsh Carson, was dismissed from the case. And the reason they were dismissed from the case is they used the typical private equity strategy, which is to get in there, invest, control, and then sell. exit the investment within 3 to 5 years, way before the FTC can catch up with its investigation. And so the court said, well, you're not imminently in control. You're not currently in control of the U.S. anesthesia partner, your minority shareholder, and you're not currently calling the shots. So even though you orchestrated this scheme, this anti-competitive scheme, the FTC's authority under, its statute is only about future and ongoing abuses. And so here's an area where you need statutory change. But also, I think that that's just telling the private equity companies, keep doing what you're doing. If you get out really fast, then by the time FTC catches up to you, you will be immune from liability. And so I think that was a big setback, even though part of it is still moving forward, and that's promising.
I hate to do this. It's been a great conversation, but we hope we've shed some light on this issue. It is quite complex. And now please, as we finish, join me in thanking Joe, Aaron, and Ken.